the 2568th birthday of Lord Buddha. So Buddha greetings to all of you. So today's topic is on osteoporosis. So it's a very, very common problem. Very common. Much more than your myocardial infarction. Much more than your malignancy. Or much more than of your diabetes or hypertension, etc. So it's a very, very common and silent killer. See, you are deliberately putting yourself at risk of ill health by being over 65. Okay, so elderly itself is a big risk factor for being osteoporotic. So in the next few minutes, I would like to talk on definition of osteoporosis, whatever the bone pathology, risk factors, male osteoporosis, skilled care, some preventive measures, and what are all the treatment aspects of osteoporosis, and finally, if time permits, vertebral fracture management also. So this is the definition according to the WHO. It is a systematic skeleton disease, no more a localized disease. It is a very big disease. It is a systematic skeletal disease characterized by low bone mass, and there is a microarchitectural deterioration of the bone tissue. Your cancellous bone, your trabecular bone, okay, spongy bone, etc. And there will be increase in the bone fragility. That is the reason they are susceptible to the fractures. So this is the osteoporosis. Here four things. One is low bone mass. The second one is the microarchitectural deterioration of the bone tissue and increase the bone fragility, and finally leading to the fractures. It was diagnosed according to your BMD, T-score less than 2.5. So less than 2.5 T-score is suggestive of osteoporosis. It is the fastest growing age group. Now the elderly individuals are very, very high in the society. So you name any country, the elderly population are increasing because of the reduced mortality because of the infections. See, earlier the number one killer is the infections. And most of the infections, they kill a lot of the individuals between the 20 years or 30 years or 40 years age group. Now the infections have reduced dramatically, and you also having a lot of the good antibiotics to tackle the sepsis also. No, even to the deaths due to the diabetes, or deaths due to the hypertension, or deaths due to the ischemic heart disease, or the CKD, they are also reduced in the number because of the interventions. Now we have the PTCA or CABG or transplantation or dialysis, etc. And a lot of the people are growing their age. Now the average age is around 70 years, or even the 74 and 80 is also possible, provided if they are health conscious. So as age increases, there are high chances of getting the osteoporosis. So it is a age-related disorders, and they are very common. They cause serious disability and excess mortality. So why you are interested in this topic is because of these two reasons. So more the disability, morbidity, and also the mortality. And finally, a major economic burden on the healthcare system. So once they are bedridden, and obviously the productivity will be lost. A lot of the people are there with the osteoporosis. If you see, 65% of the Indians aged 50 years and above are osteoporosis. So in a country of 140 crores, you can imagine 65% of the Indians above the 50 years of the age group. So you can imagine the number of the osteoporosis in Indian population. And of course, 80% of the women, especially the post-menopausal women, 50% of the women who are age 50 will sustain a fracture in their lifetime because of the osteoporosis. The condition is responsible for millions of the fractures annually, mostly involving the lumbar vertebrae, hip, and the wrist. And in the males, even the ribs also. So the common fractures we often see in the osteoporosis are the vertebral fractures, hip fractures, Colles fracture or the wrist fractures, and then the rib fractures. Fragility fractures of the ribs are also common in the male. See the incidence of the common diseases. Here, which one is common? Is the breast cancer, or the CVA, or the myocardial infarction, the heart attacks, or the osteoporosis. Osteoporosis is a very big disease here. So nearly the vertebrae are involved here, forearm, hip, and other bones like ribs, etc., etc. So osteoporotic is people at the risk of the fractures are much more common than the myocardial infarctions or the CVAs or the oncology population. See, what is important here is the risk of the second vertebral fracture within the 1 year is 20%. So second vertebral fracture within 1 year is about the 20% in the osteoporosis. So osteoporosis, we have to identify the osteoporosis at an early time, and all the preventive measures or the therapeutic measures, whether the calcium or the vitamin D3 or the bisphosphonates or resorptive drugs or anabolic hormones, etc. So that we have to increase the bone mass and we have to reduce the bone mass, and then we have to improve the new bone formation, and we have to avoid the osteoclasts. So this is the most important treatment aspect in the osteoporosis, so that we can avoid the further fractures. Otherwise, second vertebral fracture within 1 year is about the 20%. It's a major global health problem. So it's almost very, very common in almost all the countries in the world. So it's a global problem, a progressive one, and it's a dynamic one. It's a systemic one. So a progressive, dynamic, systemic skeletal disease characterized by the low bone mass and microartificial deterioration of bone fragility and increased risk. Here the age is important. Generic is also important because Asians are also more prone for the osteoporosis, and lifestyle changes, lifestyle variables, and nutrition, exercise improves the bone mass, smoking reduces the bone mass, a chronic diseases, they are more prone for the osteoporosis, and exposure to the drugs like steroids. So whenever you use the long-term steroids differently, we have to avoid the osteoporosis. So risk of the osteoporosis is very high with the people on long-term steroid therapy. So these are all associated with the rapid bone loss. So finally, they lead to the bone fragility and fractures. So this is the bone structure. The two bones, one is the cortical bone, the outer side is the cortical bone, inner one is the trabecular bone or the cancellous bone. So the cortical bone is about 80% of the bone mass, where the cancellous, the trabecular bone, is a spongy that contains about 20% of the total bone mass. The cancellous bone or the trabecular bone is formed by the interconnected structure of the lattice work. In osteoporosis, these interconnections will be lost, and there are a lot of pores. That is, the osteoporosis means bone porous. It is porous and often referred as the spongy inner structure. So because it is more metabolically active and has a large surface area, it is more susceptible to the bone loss and the fractures. So this is the cancellous bone, inner one, 20% of the bone mass. Cortical bone is a more dense type of the bone, very thick, that surrounds the cancellous bone to form the outer, more durable layer bearing the majority of the body's weight. And if you see the constituents of the bone, both inorganic and organic, inorganic in about 65% and organic in 25%. Inorganic contains crystalline hydroxyapatite, amorphous calcium phosphate, trapped ions like citrate, fluoride, sodium, magnesium, potassium, etc. So these are all the inorganic constituents, about the 65%. Whereas organic, 25%, the cells, your bone cells, 4%, and the matrix, 21%. So these are the important 4 cells. One is osteocyte, it maintains the bone tissue. Osteoblast, they form the bone matrix. And last one is the osteoclast, they resorb the bone. These two you should remember, osteoblasts and osteoclasts. So osteoclasts, so they damage the bones. Osteoblasts, they forms the bones. Okay, so the form the bone matrix is osteoblast, that is healthy, we are helpful. Osteoclasts are harm, they cause resorption of the bone. And osteogenic cell, this is the stem cell, so from there these cells will origin. So finally, we have the three types of the cells: osteoblasts, osteocytes, and osteoclasts. Interact with a variety of the minerals, proteins, hormones, water, and other molecules to nourish the bone, and resorption of the old or worn bone tissue and replace it with a new bone in a process called remodeling. So that remodeling is a continuous process. So there will be the resorption of the bone, and then there will be the formation of the bone. So that is a big cycle. Both the osteoblasts and the osteocytes are derived from not yet differentiated precursor. They are mostly the mesenchymal stem cells that can also be stimulated to become the muscle, fat, or cartilage, but under the right conditions can differentiate to form the new bone cells. During this remodeling process, osteoblasts lay down orderly layers of the bone that add strength to the matrix. Some of the osteoblasts are buried in the matrix as it is being produced, become the osteocytes. They are the bone cells. So some are buried, they becoming the bone cells. Some are on the outer layers, so they give the strength to the bones. Other osteoblasts remain as the thin bone cells that cover the surface of the bone called the lining cells. Osteoclasts, they are the cells that remove the old or the damaged bone by dissolving the mineral and breaking down the matrix in a process called bone resorption. So bone resorption by the osteoclasts, so that remove the old or the damaged bone by dissolving the mineral and break down the matrix. Under the normal conditions, the functions of the osteoblasts, that is the formation, osteoclasts, that is the resorption, are coupled with signals from one affecting the other to maintain the balance between the breakdown and the new bone formation. So they go hand in hand, osteoclasts and osteoblasts. To osteoporosis, when it appears, so when there is an imbalance between these two, when there is less of the osteoblasts and more of the osteoclasts, then you will become osteoporotic. So this is an imbalance between the bone resorption. So the more bone resorption than the bone formation, in which case bone resorption significantly exceeds the bone formation, then the osteoporosis will occur. This is an imbalance, like your obesity. Okay. Body begins to lose bone more rapidly, leaving the bones weaker and the more susceptible to the fractures. So this is the bone remodeling. So you should remember the osteoblast, osteoclast, resorption and the formation, and imbalance between the osteoclasts and the osteoblasts, leading to more and more resorption and less formation. So these become very porous and fragile and get fractured. So the removal and the replacement of the bone in the remodeling cycle involves the 4 phases. One is the activation, resorption, a period of reversal, and bone formation. Signaling the start of the activation stage, the cells of the osteoblast lineage act on the blood cell precursors. So they are the hemopoietic cells to produce more bone resorbing osteoclasts. So that is the activation phase. What about the resorption process? It may take place under a layer of the lining cells. During this stage, new army of the osteoclasts removes the worn or the damaged bone by dissolving the mineral and breaking down the matrix, leaving the small cavities in the surface of the bone. So it leaves the small cavities after the resorption of the dead bone. That is the resorption process. So this is the diagrammatic showing you. So beginning one is the lining cells, and then the osteoclast precursors, they activate, and then the bone remodeling will be there, and finally you see the layer at the right hand, a good layer with mineralization and cement lines, etc. So this is all the resting surface, initial evacuation, reversal, osteoid synthesis, and finally completed a new bone formation. So this resorption phase takes for about the 2 to 4 weeks, whereas the formation phase takes about 4 to 6 months. See, after a period of the quiescence, that the reversal, the osteoblasts, they appear in the increased numbers and repair the bone, filling the recently excavated cavities with the new bone. So see here, the reversal one. The center one, the empty one, big one. So that is the phase of the reversal. The bone remodeling continues throughout the adulthood, with each remodeling process lasting about 6 to 49 months. During the adult lifetime, the bone is replaced about every 10 years. But in elderly individuals, so this replacement will not be there, and then there will be the shortening of the bone and shortening of the height. All these things will occur, and kyphosis, etc. What is the biological messenger molecules? The systemic factors involved in the calcium homeostasis, the local factors influencing the bone cell function, cytokines and colony stimulating factors associated with the regulation of the osteoclast and the development, growth regulatory factors that stimulate the osteoblastic proliferation and differentiation from the progenitor cells. See again the same picture. Here the osteoclast, growth factors, calcium, osteoblasts and the lining cells. So these are the links. Now the hormones and the growth factors regulating the bone formation. See, to understand the osteoporosis, these are all very important. So these are the basics. So what you mean by the bone, what are the structures, what is osteoblast, what is the osteoclast, what is the role of the calcium, what is the role of the hormones like parathyroid, etc. So this basic understanding is very important for our medicine postgraduates. So otherwise, no, the management of the osteoporosis is very, very difficult. It's not just like writing the calcium or vitamin D3. Okay, so much more than that, because it's a very, very big problem and a very common problem. See the interleukins, interleukin 1, 3, 6, 11. The target cells of the tissues, they are the bone marrow and osteoclasts. In fact, they stimulate the osteoclast formation and the resorption. So to stimulate the osteoclast formation and the resorption, so this is also good for your remodeling. So once the resorption is there, then your body new bone formation will start. So here the interleukins will help in the bone resorption. Okay. Then the tumor necrosis factor alpha or the granulocyte macrophage stimulating factors like GM-CSF. So these two will the targets on the osteoclasts. They stimulate the bone resorption again here. So the interleukins, tumor necrosis factors, so the granulocyte macrophage stimulating factors. So these are all effects on the bone resorption. So the leukemic inhibitory factor, osteoblasts and osteoclasts, they act on both osteoblasts as well as the osteoclasts. So stimulate the osteoblast and osteoclast formation in the marrow. Because if you understand these things later, you can have a new drugs which can work on the osteoporosis. So they are the interleukin or monoclonal antibodies are also available for the management of the osteoporosis right now. So for that we need this basic understanding. Parathyroid hormone is a very, very important hormone in osteoporosis. The target cells are the bone and the kidney. In fact, they stimulate the productions and helps the resorption of the calcium. Calcitonin, so that is also very important on bone osteoclasts. So it inhibits the resorptive action of the osteoclast, lowers the circulating calcium. That is the calcitonin. So that is available for the therapeutic purpose. Parathyroid hormone is available for our therapeutic usage. Calcitriol, you all know that most active form here. So 125 dihydroxy vitamin D3. So that act on the bone osteoblasts, kidney and the intestines, stimulates the collagen, stimulates the cell differentiation, calcium retention, calcium absorption. Estrogen is a very, very important. So target cells is the bone, stimulates the formation of the calcitonin receptors, inhibits the resorption, stimulates the bone formation. So in the post-menopausal women, so as they are lacking the estrogen, so these things will occur. So stimulation, formation of the calcium receptors won't be there, and it won't inhibits the resorption and don't stimulate the bone formation because of the lack of the estrogen. And this is a very, very, very important post-menopausal osteoporosis in our population. So most of the times now we can give the hormonal replacement therapy also. It may be needed in some individuals, especially the post-menopausal women who are facing very severe osteoporosis. Testosterone is also equally important. It acts on the muscle and the bone, muscle growth, placing the stress on the bone to stimulate the bone formation. Prostaglandins, they act on the osteoclast, stimulate the resorption and the bone formation. Bone macrophagic, bone morphogenic proteins, mesenchyme. So after of them, parathyroid hormone is important, calcitonin is important, calcitriol is very important, estrogen is very, very important, and testosterone and prostaglandins are also equally important. See the normal bone versus the osteoporotic bone. See the difference between the normal bone and the osteoporotic bone. So that is the reason the second bone can be easily break down. So easily fractured. So the normal bone shows a pattern of strong interconnected plates of the bone. Much of this bone is lost in the osteoporosis, and the remaining bone has a weaker rod-like structures, and some of the rods are completely disconnected. So a simple fall on the ground may make the femur fracture, maybe the vertebral fracture, compression fractures, or wedge compression of the vertebra. So these are very common because of this architectural loss. These bits of the disconnected bone may be measured as the bone mass, but contribute nothing to the bone strength. So osteoporosis is a metabolic bone disease, okay, and a systematic bone disease with osteosclerosis, osteolysis, and osteoporosis. See the difference between the normal bone and the osteoporotic bone. So it leads to the low bone mass and reduced bone quality. So the result is fracture, early fractures, because of the low bone mass and low quality. See the difference here. Okay. So the bone structure, you have the cortical and the trabecular bones and the bone cells. If you see here, you will have the osteoblasts, osteocytes, osteoclasts, so organic cells and the matrix. The same thing what I have told so far is the collagen, about 95%, and non-collagenous proteins, about the bone proteoglycans, ioloprotein, etc. Bone turnover. So osteoclast is the bone resorption, osteoblast is the bone formation. So formation and resorption should be hand in hand and equal proportions. Otherwise, so there will be the osteoporosis when the resorption is more and the formation is less. And finally, increased bone fragility and the fractures. So the same thing, the bone turnovers. So the bone metabolism. See the dietary calcium and the phosphate. So they, after food intake, so from the intestines, so that will be absorbed into the extracellular fluid, and there will be the activation of the parathyroid hormones. So this parathyroid hormone, not only the parathyroid hormone, the calcitonin also. So the finally they act on the bony tissue, bones. So here the intestines are important, the extracellular fluid is important, the bone is important, parathyroid hormone is here, and also the nephrons or the kidneys. So the kidney, intestines, parathyroid hormones, they play a major role in the homeostasis of your osteoporosis or the bone structures. Here the parathyroid hormone regulates the conversion of the 25 to 125. So for the conversion, the most active form, you need the parathyroid hormone. And parathyroid hormone increases the resorption of the calcium and decreases the resorption of the phosphorus from the glomerulus, from the convoluted tubules. And your 125 dihydroxycholecalciferol that stimulates the absorption of the calcium and the phosphorus from the gut. So again, parathyroid hormone helps here. And then calcitonin suppresses calcium release by suppressing of the osteoclast. Parathyroid hormone releases the calcium from the bone. So these are all the structures are involved. So to know the bone metabolism, so you need to understand the role of the intestines, role of the calcium and the phosphorus, role of the parathyroid hormone, role of the calcitonin, and role of the kidneys in formation of 125 dihydroxycholecalciferol. So these are all very, very important structures are involved in the clear-cut understanding of your bone metabolism. There the certain local factors are also there. Some systemic hormones involved systems. Here the three systemic hormones are the parathyroid hormone, vitamin D3 and calcitonin. Okay, involved systems, bones, intestines, and the kidneys, and also parathyroid hormones. See the peak bone mass, a lot of the factors are involved here. Genetic factors are also very important, nutritional factors, some hormones, exercise is very, very important. So the lack of the activity, so the physical inactivity itself is a big risk factor for the osteoporosis. Bone strength, it is related to your bone mass measured by your BMD. So once the BMD is less than T score less than 0.25, 2.5, you consider it as the diagnostic of your osteoporosis. And other factors such as the remodeling frequency, that is the bone turnover, bone size, bone area, bone mineral architectures, and degree of the bone mineralization. So these are all important for your bone strength. See, osteoclasts, they are the mineral content of the matrix is first dissolved and the remaining protein components of the matrix, primarily the collagen, are then degraded by the proteolytic enzymes secreted into the resorption space. Osteoblasts, they synthesize the new bone by first laying down a new protein matrix, principally composed with the type 1 collagen, into the resorption space. So the bone mineralization occurs with the deposition of the hydroxyapatite. The markers, bone turnover markers, the formation and the resorption. So the bone specific alkaline phosphatase and osteocalcin. So these are the markers of the bone formation. And bone resorption, you have the N-telopeptide and C-telopeptide and the deoxypyridinolene. See the center one. So that is the right posture. So we are all from these things, primitive animals, and then we have become so straight, and later, and then again going back to the bending forward, flexion, flexion. So again going back to the creature, so causing more and more osteoporosis. So to avoid the osteoporosis, so again activity is very, very important. Physical activity is very, very important. Physical inactivity is a big risk factor for the osteoporosis. So here aging, hypogonadism, menopause, risk factors, high bone turnover, they all increases the bone loss. So that leads to the low bone density, impaired bone quality, and more fat, falls, and then finally some fractures. So the bone mass changes, peaks by mid-30s. So the highest bone mass will be seen in your age group. So around 30s, you will have the maximum bone mass. Bone loss begins several years prior to the menopause. So once 45, 50 years, it starts breaking down. And risk of the fracture increases with the BMD loss. Genetic factors contribute 80% to a woman's risk of the osteoporosis. Very, very important genetical factors. See, 50% greater if the first degree relative had a family history, strong family history. 127% greater if the parent had a fracture. So these fractures and osteoporosis also runs in the families. So the only antidote to that is physical activity. Physical activity, cessation of the smoking, moderation of the alcohol, avoidance of the steroids. Okay, and these are very important environmental factors to conquer osteoporosis. Otherwise, if you have a strong family history of the fractures in the family, so definitely we are going to have osteoporosis and fractures also. What are the modifiable risk factors? So inadequate exercise is a very big nowadays. So that is the reason obesity is increasing like anything, and we are seeing early onset type 2 diabetes in the young children because of the physical inactivity. So the exercises are very, very important to avoid the osteoporosis. Inadequate nutrition, especially the calcium, vitamin D, balanced diet. So unfortunately the fast foods, okay, high calorie diet. So they won't contain the calcium or the vitamin D or the balanced diet. More of the saturated fats, trans fats, etc. So that could be another reason for the osteoporosis nowadays. So balanced diet is very, very important. More fruits, more green leafy vegetables, more dal, more milk, more yogurt, more curd, low dairy farms. So these are all very important beans. Okay. So these are very important food items one should take to avoid the osteoporosis. So the medications, so one should be very careful in prescribing the steroids. As and when required, only we have to write the steroids. But unfortunately in India, a lot of the RMPs, they prescribe steroids. Most of the drugs they prescribe, number one drug they prescribe with the RMPs is the steroid one. So we have to avoid the steroids unless otherwise it is indicated. And excess thyroid, so in hyperthyroidism, smoking definitely increases the bone turnover, and excessive alcohol intake. So that also increases the osteoclasts and reduces the osteoblast formation. So they are the modifiable ones. So we have to concentrate on these factors in osteoporosis, because very little can be done as far as the drugs are concerned, because these drugs are very costly. These drugs are mostly having the side effects. So before the drugs, we have to consider the non-pharmacological management of the osteoporosis. Here, these will help you a lot in preventing the osteoporosis or in reducing the osteoporosis. Again, I am saying that exercise is important, nutrition is very important, calcium intake, vitamin D intake, balanced diet, avoidance of the steroids for a longer period, and then if the patient is in hyperthyroidism, so make them the euthyroid as early as possible, and cessation of the smoking, and no alcohol at all. If the patient is in a chronic alcoholic, at least moderation of the alcohol is good. So these are all the important modifiable factors one should concentrate to avoid the osteoporosis. So the non-modifiable, because we can't change our parents, so the genes are very, very important. So gender, again, the more common in the post-menopausal women. It is also more common in the men aged more than the 70 years of age group. More common in our Asian Indians. The race is important. Age is very common in the elderly individuals. So the more the age, the more the chances of osteoporosis. So these are non-modifiable. So age, race, gender, and your genes. So the same thing again, the risk factors. So age more than the 70 in the males, and females age more than the 50 years are postmenopausal. Hypogonadism. So that is the reason testosterone levels or estrogen levels, one has to check it. Fragility fractures, when the patient is having a fragility fracture, again, there is a risk factor for the future fractures. So already told you, osteoporosis. So within the 1 year, there are 25% people, they have the second fracture. Hip fracture, glucocorticoids, steroids therapy, high bone turnover, anorexia nervosa. The lower the BMI, the more the chances of having the osteoporosis. So the anorexia nervosa is again a big problem for your loss of appetite or vomitings, etc. for the low BMI. So here the BMI less than the 18. That is the normal BMI is 18.5 to 23. Okay. Immobilization or sedentary lifestyle is a big risk factor. A CKD is again a big risk factor because it involves with your calcium absorption and the phosphate absorption and the resorptions. So transplantation, you use a lot of the steroids, you use a lot of immunosuppressive drugs there. And chronic inflammatory diseases, again, there is a chances of having the osteoporosis. Estrogen deficiency in the postmenopausal women, calcium intake less than the 500 milligrams. Usually we need about 1000 milligrams a day, 1000 to 15 milligrams a day. So calcium intake. So once the fellow is taking the more and more milk, 1 cup of the milk contains about 300 to 400 milligrams of the calcium. So 1 cup of the yogurt that contains about the 300 milligrams of your calcium. So at least if the patient is not taking these type of the items, so I have to give the calcium tablets. So at least 500 milligrams 3 times a day. So one should not consume 1500 or 1000 milligrams of the calcium at a time. So when you are giving the calcium, at least you give the BD doses or the TAD doses for the proper absorption. So the primary hyperparathyroidism is again a big risk factor for your osteoporosis, rheumatoid arthritis, hypercalciuria, anticonvulsant therapy, of course the diabetes, smoking and alcohol. So these are all the different risk factors. So as a physician, so you should concentrate on these factors, so to avoid the osteoporosis. So unless you concentrate these factors, unless you address these factors, so it's very, very difficult to maintain osteoporotic individuals not to have the future fractures. So what are the consequences of your osteoporosis? So reduced quality of the life. Yes. There is an increased mortality. and failure to return to the baseline. So because of the immobility and depression. So depression is a very, very common in severe osteoporosis individuals. As I told you, I will take a talk on anxiety and the depression at a later time. Very, very important for our physician point of view, because a lot of the people in the society, so they are facing this problem of anxiety and the depression, including you. So risk factors for osteoporotic falls. Okay. So the body weight less than the 70 kgs, BMI less than not 21, maybe 18. Steroid, the same thing here. The first degree related with the fractures, smoking, early menopause. So these are all the important risk factors. Screening methods. Okay. So this is the DEXA scan. So that is the investigation of the choice to detect the osteoporosis. What you mean by the DEXA? That is the dual energy X-ray absorptiometry. So DEXA, dual energy X-ray absorptiometry is the DEXA. It is available in almost all the places. So here the preferred femoral neck BMD is the best predictor of the hip fracture. So they get the femoral neck BMD, they get the hip BMD, and also in the forearms BMD. Okay. So the forearm BMD predicts the non-hip fractures. In the same way, the other way of getting this, when the BMD is not available in that particular place, even the ultrasound densitometer also can give you a picture about the osteoporosis. But the gold standard is the DEXA that is available in Kakinada and Rajahmundry. How you classify the osteoporosis? So this is an Nordin's classification, generalized or the localized. So generalized, again the primary or the secondary. In the primary you will have the post-menopausal or the senile, and some secondary causes. Already told you all the secondary causes. And the localized osteoporosis is also there. Localized osteoporosis is also there, but it is very, very minimal. But mostly it is the generalized. And the Riggs and the Melton classification. So he said the primary osteoporosis is the type 1 and the type 2. So already told you the type 1 and the type 2. Type 1 is the post-menopausal and the type 2 is the senile. And secondary osteoporosis, already I told you several conditions of the secondary osteoporosis conditions. And osteogenesis imperfecta and idiopathic juvenile osteoporosis. See, juvenile osteoporosis. So that is also common. So unless you address this juvenile osteoporosis, so whatever amount of the drugs you prescribe it is of no use. So it's worthwhile spending some time on the post-menopausal osteoporosis. So very, very common in our society. It characteristically affects the women between 10 and the 20 years following the menopause. And some women are even immediately after the menopause also. You need not wait for the 10 years also. Even the less than the 5 years also, most of these people will become osteoporotic, provided if they are diabetic, provided if they are hypertensive, provided if they are the, say, nutritious imbalanced diet. So these are very common. Here the sex ratio is a 5:2. PTH and calcium metabolism is the decreased, characterized by the high bone turnover and the rapid loss of the trabecular bone. They suffer acutely painful crushing fractures of the vertebrae and Colles fracture of the distal radius. So the very common fractures of the vertebrae and the Colles fractures in the postmenopausal women. The second group, the primary osteoporosis, are two types, type 1 and type 2. Type 1 is postmenopausal and type 2 is the senile. Here affects the men and the women aged over the 70 years. Due to the chronic effects of the bone loss, since the peak bone mass attained in the fourth decade with a superimposed senile lowering of the rate of the bone turnovers, affects both the cortical and the trabecular bone. I told you what you mean by the trabecular bone and the cortical bone. Cortical bone is the outer layer, very thick, whereas the inner one is the trabecular bone. It is a spongy. PTH is increased or reduced calcium absorption, and 125 dihydroxy vitamin D3 synthesis affects in the PTH. Decreased insulin-like growth factor concentrations, characterized with the multiple wedge fractures of the vertebra, often pain-free, asymptomatic. So they didn't know that they had a wedge fracture of the vertebrae unless you take an X-ray. And fractures of the femoral neck and the intertrochanteric femoral fractures. So secondary osteoporosis, pharmacotherapy is a very common steroid therapy, thyroid over replacement, your hypothyroid management, anticonvulsants, phenytoin, lithium, heparin, long-term uses of the heparin, and drugs producing the hypogonadism, like antimetabolic chemotherapies, mostly chemotherapy drugs. Endocrine disorders, Cushing's, hyperparathyroidism, hypogonadism, hyperthyroidism. Some gastrointestinal disorders, like alcohol abuse related diseases. So when they are excess alcoholism or binge alcoholism, so there are all chances of having the falls and the fractures. Malabsorption syndromes, so connected with your calcium absorption in malabsorption. Eating disorders, okay, they eat only the high dense calorie diet, so they don't like the balanced diets. Celiac disease, again absorption will be a defect. Inflammatory bowel disease, chronic liver diseases, gastrectomy. So these are the gastrointestinal disorders concerned with your calcium and phosphorus metabolism or digestion. Some genetic diseases like osteogenesis imperfecta and hypophosphatasia. Other reasons, the organ transplantation, rheumatoid arthritis, some neurological diseases, spinal cord injury, multiple sclerosis, prolonged bed rest, multiple myeloma, and marrow infiltrative diseases like myelodysplastic syndromes, etc. Okay, so these are all the different secondary causes. So as a physician, so we should know all these things. So what about the drugs? What about the endocrine disorders? What about the gastrointestinal disorders? And some miscellaneous causes like our autoimmune diseases, etc. So the tests that should be considered when evaluating the secondary causes of the osteoporosis. What are all the tests? Already one test I told you, the gold standard test is the DEXA scan. Okay. So more than that, history is very important. Examination is very important. So to rule out the secondary causes, etc. And the 25 vitamin D3 is also to be done. High serum calcium, hyperparathyroidism or malignancy, low serum calcium, malnutrition or osteomalacia, serum phosphorus, alkaline phosphatase, creatinine. So to rule out your CKD, parathyroid hormone increase in the hyperparathyroidism, decrease in the malignancy, low urine calcium levels, that is an osteomalacia, malnutrition, malabsorption, high urine calcium, male osteoporosis, granulomatous disease or malignancy with increased bone turnovers, TFTs, protein electrophoresis to rule out the multiple myeloma, and testosterone levels. So there are all the investigations one may need in some individuals. So the most important one is the DEXA, and again you can get the vitamin D3 levels, you can get the serum calcium levels, serum alkaline phosphatase, creatinine levels, parathyroid hormone, and calcium in the urine, maybe low urine calcium or high urine calcium, thyroid function test, protein electrophoresis to rule out the multiple myeloma, and testosterone levels to rule out hypogonadism. So there is the bone turnover markers, the measures of the osteoblast function, alkaline phosphatase and osteocalcin. See, alkaline phosphatase very often we do it. The bone alkaline phosphatase is specific for the bone and reflects the cellular activity of the osteoblasts. Osteocalcin is a hydroxyapatite binding protein synthesized by the osteoblasts. So these are the bone turnover markers. Measures of the osteoclast function, hydroxyproline and collagen cross-links. These include N-tylopeptide, C-tylopeptide and deoxypyridinoline. So we rarely get these investigations, but often we get the alkaline phosphatase. Silent fractures, they are very important in osteoporosis. So check for the loss of the height. So there will be the more than the 5 centimeter height, loss of the height will be there because of the silent fracture of the vertebra. Up to 70% vertebral fractures may be asymptomatic. In the evaluation of the 2 primary care offices only, 35% or 38% of the patients with a history of the vertebral fracture were evaluated for and treated for the osteoporosis. So a lot of the people, they keep on living with the silent fractures even though their height is reduced because they don't complain, asymptomatic. So a word about the male osteoporosis. The morbidity and the mortality much higher in the men than the women with osteoporotic fracture. Secondary causes more common, accounting for the 50%, the ethanol, glucocorticoids, and hypogonadism. These three are very common in the male osteoporosis, male senile osteoporosis. So alcoholism, steroid therapy, or hypogonadism. So low testosterone levels. 3 to 6% of the men in the US, 28 to 47% with osteopenia. The average onset is 10 years later than in the women. So in senile osteoporosis in the men, so occurrence much later than women. Men often asymptomatic at the onset. Previously, no formal recommendations to detect it, but now WHO recommends the BMD for all men more than the 70 years of age group, because a lot of the people are having a silent osteoporosis. So silent osteoporosis, if you don't detect, so they will end up with the fractures. So the more the fractures means again the depression, so the quality of the life will be disturbed and there will be more mortality. So for the WHO recommends that BMD is also for the men more than the 70 years of the age group to detect asymptomatic osteoporosis. Even at the age of 50 to 70 years in all the men, if they have the risk factors. So risk factors like steroid therapy, risk factors like hypogonadism, or risk factors like hyperthyroidism or hyperparathyroidism, or any gastrointestinal disorders, or any some endocrinal disorders. So definitely we have to screen for that, even though they are aged between 50 to 70 years of age group. BMD should be compared to the male references so that the osteoporotic diagnoses are not missed. You compare when you are taking the male osteoporosis markers, so you compare with the male counterparts. Otherwise, if you compare the female counterparts, so most of these men will be osteoporotic. BMD of the hip is most reliable indicator due to the prevalence of the spinal degenerative changes. In senile population, so they will be having the lumbar spondylosis or lumbar lordosis. So to get the BMD of the vertebral joints, vertebrae, so it gives you a false positive results. So better to have the hip BMD in all the senile populations to have a clear-cut BMD so that you can diagnose the osteoporosis more accurately. So, when to suspect the secondary causes? So the premenopausal woman, patient without the risk factors, men less than the 70 years of the age group, multiple health problems, and worsening osteoporosis despite the therapy. So have to suspect some secondary cause. So these are all the secondary causes already I discussed. So the labs also we discussed. And imaging. X-ray is not good for early detection. 20 to 40% of the BMD must be lost to the detect. So osteoporosis means fractures, pain, deformity, and loss of quality of the life. So they conduct every October 20th as the World Osteoporosis Day every year, October 20th. See the traditional picture of an individual with osteoporosis. Okay, stooping forward, kyphosis. An elderly female with a thoracic kyphosis due to the idiopathic osteoporosis, so-called Dowager's hump. An elderly woman with a curved back and stooped posture, a woman who has lost height and who appears small and frail. So there will be a loss of about 5 centimeters height less. So this is a senile osteoporosis because of the curved back and loss of the height and the more friable. See the pictures here, vertebra. See the wedge compression fractures. Okay. See the vertebrae, spongy vertebrae. They thinned out. They're small in size. See, concentrate on the L4 vertebra. So here the post-menopausal, here the senile is related. So both are reduced in the height, stooping forward, some kyphosis, etc. Okay. See some of the other reasons. Prolonged bed rest of any general inactivity. So definitely leads to osteoporosis. So prolonged casting or the splinting. So especially in the ortho wards. Disuse. So paralytic people, quadriplegia, paraplegia, hemiplegia, or motor neuron diseases. So they are more prone for osteoporosis. Nutritional, here the deficiency of the calcium, protein, vitamin C, and more alcoholism. Drugs, heparin, ethanol, steroids, etc. Idiopathic adolescents, that is juvenile osteoporosis, and the elderly, so that is the senile osteoporosis. Some genetics, so osteogenesis imperfecta or homocystinuria. In the hand, that is the rheumatoid hand, and the liver, that is cirrhotic liver, and the kidney, renal tubular acidosis, and the bone, the neoplasms, bone marrow tumors like myeloma, multiple myeloma, lymphoma, leukemia, etc. And here the pituitary, ACDH hypersecretion tumor, and the adrenal cortex, so hyperplasia or Cushing's, etc. In the ovary, so the deficiency of the estrogen, maybe post-menopausal, and the testis, testosterone deficiency. In the parathyroid, hyperparathyroidism may be primary or the secondary, and in the thyroid gland, hyperthyroidism. So finally, the post-menopausal or the age related. So in a single slide, so they are given most of the reasons of the osteoporosis. So major osteoporotic fractures, if you see the Colles fracture, vertebral fracture, and the hip fracture, so more. So to avoid these fractures, so you have to concentrate on the management of the osteoporosis. See the progressive loss of the height. So development of the kyphosis. So the first picture, the second picture, and the third picture. See the height, reduction in the height. Okay. See the hip fracture. Typical appearance of the patient with the fracture of the right femoral neck. See the foot. Impact intracapsular fracture of the femoral neck. Non-displaced fracture. Here the displaced fracture in the third one, last one. And then non-displaced intratrochanteric fracture of the femur. So complication of the spinal osteoporosis. Bed rest only. Moist heat. Assisted ambulation. Okay, gradual mobilization about 2 to 5 weeks. Thoracic hyperextension, orthosis as tolerated. And then sometimes, as soon as the pain permits, so there's a swimming, excellent rehabilitation exercises, etc. Okay. So results of the osteoporotic fractures, pain, reduction of the physical activity, deformity, muscle weakness, isolation, loss of independence, and increased mortality. So that is the reason we are interested in the osteoporosis. Okay, to reduce the pain, to improve the physical activity, so not to get deformed, improve the muscle strength. Okay, and he should be socially active, and should be independent of his own activities, to do the own activities, and to avoid the early mortality and morbidity. So that is the management, that is our aims of the osteoporosis treatment. See here the radiographic evaluation. End plate deformity, fish vertebrae, number 2, 3 is the end plate fracture, wedge vertebrae, and then the compression fractures. So we often see in X-rays, so compression fractures, wedge compression, etc. So these are the diagrammatic representation of your radiographic spinal vertebrae. See thoracic spine, pain in osteoporosis, diffuse vertebral osteoporosis causing the wedging. See here in the first picture, in the second picture, wall and occiput distance. So calculate the occiput and the wall, the distance between the wall and the occiput. So the normal population, they can touch the wall. Whereas in the severe osteoporotic individuals, because they are far inward, there will be a gap between the wall and your occiput. So they calculate that, how much different distance is there between the wall and the occiput. In the same way, rib and pelvis distance. Okay. In the second picture, third and the fourth one is the rib and the pelvis distance. So the no single maneuver is sufficient to rule in or rule out the osteoporosis or the vertebral fractures without further testing. So here the two tests are a positive test, that is wall and occiput distance, and the second one is the rib and the pelvis distance. See the third picture, you have seen the four fingers between the ribs and the pelvis, and in the last picture only the two fingers between your ribs and the pelvis. So very easy to carry and very easy to identify the osteoporosis by noting these things. So you don't need much costly investigations except the DEXA. So what are the indications for your DEXA scan? See, as I told you, the most important investigation is the DEXA, or to know the T-score less than the 2.5 or less than the 1 or 1.5, etc. So what are the indications for this scan? So the female patients, mostly the menopausal women, maybe 60 years or 50 years or 65, are patients with osteoporosis risk factors. So what are all the secondary risk factors I told you? So any vertebral abnormalities under osteopenia and X-rays, when X-ray shows some abnormalities in the vertebrae, so definitely there is a scope for the DEXA scan. And long-term steroid therapy, a primary hyperparathyroidism or other diseases with a high risk of osteoporosis. Patient being treated for osteoporosis to monitor the changes in the bone mass. So for monitoring purpose also, those people who are on chronic therapy for your diagnosis of the post osteoporosis. So this is the very important. See the normal one, 0 to -1 standard deviation. So they compare with the younger individuals. So younger individuals may be aged about 25 or 30 years of the age group. So they compare this bone mass with the younger individuals. So there is a normal is 0 to 1, osteopenia -1 to -2.5, and osteoporosis -2.5, and established osteoporosis. So this with the fracture. So that's how, according to the BMD, you can differentiate between the osteopenia, osteoporosis, and established osteoporosis. Okay. So we should consider the osteopenia also, because these people, so if you don't, if you leave the osteopenia people, so they will be entered into the osteoporosis, like your pre-diabetes entering into the diabetic individuals. Okay. So what are the recommendations based on your BMD? BMD is a normal. So that means what is the score? 0 to -1. So the very low risk, fracture, risk of the fractures very low. So what is the action you take? Preventive measures. Osteopenia, so -1 to -2.5. So risk of the fractures, again the low, but the action you have to take the preventive measures. Okay. And establish osteoporosis and also osteoporosis of the severe grade. So there the treatment is needed. So this is the very important. Okay. So the treatment is needed for all the osteoporotic individuals, also with the history of the fractures. I feel that even some people, they need the treatment, even in the osteopenia also, provided if the chances of having the osteoporosis are very high in the near future. So this is your DEXA scan, the most common test. Results are reported using the T-scores. The T-scores are the relatives to how much higher or the lower your bone density compared to that of a healthy adult. The healthy adult is with a good bone mass, so around the 30 years of the age group. So they compare how much higher or the lower your bone density when compared to the healthy adult. T-score, it is the number of the standard deviation above or below a reference value. So the same here. So the normal bone density, so 0 to -1, -1 to -2.5 is the osteopenia, and less than -2.5 is osteoporosis. What is BMD? The amount of the mineral matter per square unit of bone. A dual energy X-ray absorptiometry measures the density in the radius in the lumbar spine and the greater trochanteric, that is in the hip. Mass of the bone mineral in the path of the beam divided by the cross-sectional area of the beam. So other methods, when the DEXA is not available, so you can go for the vertebral fracture assessment or CT or the ultrasound. Here not only the T-score, there is also Z-score. But T-score is diagnostic of your BMD. Z-score is a comparison of the age-matched normal and is usually used in case of severe osteoporosis. So the T-score we compare with the young adult, whereas the Z-score we compare the same age-matched normal individuals. Here age-matched symptomatic individual with your osteopenia or osteoporosis, you compare the age-matched normal individual without any osteoporosis. So that is the Z-score. The negative scores indicate the lower bone density and the positive scores indicate the higher. So in osteoporosis, we have the low bone mass. So the scores will be negative scores. So the minus scores. So what is the WHO definition of osteopenia? BMD 1 to 2.5 standard deviations below the young normal is the osteopenia. And osteoporosis, BMD falls 2.5 standard deviations below the mean of the young healthy adult of the same sex, also referred to as the T-score. So these are the prevalence of these individuals, very high, both osteoporosis and osteopenia. So the 10-year probability of the fracture in women by age and the T-score. So as age increases, see here, okay. See the numbers here. So even at the younger age group, maybe at the 50 years of the age group, so a lot of the people will be having T-score more than the 2.5. So in the 50 years of the age group, T-score minus 2.5, 11.3%. Minus 3, 14.1%. So combine the 11 plus 14, nearly 25. So 25% of the people, even at the age of the 50 years of the age group, so they are having very severe osteoporosis. Okay. So as age increases, so even at the 75 years of the age group, so even the T-score at minus 1 is also at high risk. So that red means high risk individuals, high risk individuals. So as age increases, even your T-score of minus 1 is also more osteoporotic. So provided if the age is 70 or 75 years of the age group. So these are all the routine biochemistry, calcium, phosphorus, alkaline phosphatase, creatine, etc. Complete blood counts. See some differential diagnosis. So not all are because of your osteoporosis. Sometimes metastasis. Because osteoporosis means you are dealing with the senile individuals. So again the senile individuals, the chances of having the malignancy is also very high. So undiagnosed primary. So they may be having a secondaries in the vertebra. So this is the metastasis. The first one is the metastasis. The second one is the multiple myeloma. Okay. And the third one is your osteoporotic fracture. So you should differentiate between the osteoporotic fracture and multiple myeloma and secondaries in an elderly individual. So otherwise the treatment varies. So if you neglect the metastasis or the multiple myeloma and think that it is because of the osteoporosis, then these people will become more and more sick and maybe early mortality. So the diagnosis is very important for as a good physician. So these are the two common diseases in the elderly individuals. So how to rule out the multiple myeloma and the secondaries, metastasis. See the exercises plays a major role. Sunlight, vitamin D3, and the last one is the fruits. So the fruits, sunlight and exercise, these three are the three mantras to prevent osteoporosis. Okay. So the nutrition, activity and vitamin D in the sun is very, very important. Nutrition, activity and the sun exposure. So the preventive fractures, the medical therapy and the prevention of the falls improves the physical function, improves the quality of the life. So these are very important. So I am told in the first one for the final years exam going people. So discuss among yourself. Okay, that is very important. Steroid-induced osteoporosis. So it reduces the bone formation and accelerates the bone resorption. Steroids. So how they are involved in the osteoporosis steroids? In both the ways. In one way, they increases the bone resorption, accelerates the bone resorption. On the other hand, they reduces the bone formation. So the finally osteoporosis on T-score -1 or -1.5 or -2.5. Direct inhibitory effect and increases the apoptosis in the osteoblasts, decreased production or insulin growth factors, decreased testosterone production. So these all leads to reduced bone formation. So reduced bone formation because of these things. And what about the increased bone resorption? So the increased osteocyte apoptosis, inhibition of the gonadotropin secretions, increases the PTH secretion. So bone loss is related to the dose. Doses as little as 10 milligrams a day may have adverse effects on the VMD. So most of the times now, we give the prednisolone even the 10 mg also for the lupus, for the rheumatoid arthritis, for erosive rheumatoid arthritis, for in systemic sclerosis. Okay. So even in the dermatomyositis or in atopic individuals. So we use a lot of the steroids, maybe the 10 milligrams or the 5 milligrams or 7.5 milligrams. So doses as little as 10 milligrams a day may have an adverse effects on the BMD. So those people are the steroid therapy. So one should be very careful to avoid the osteoporosis risk in those individuals. So what about the localized osteoporosis? So this is diffuse osteoporosis. So the people admitted in the orthopedics wards, a prolonged bed rest or paraplegia or quadriplegia, the pseudex osteodystrophy, transient osteoporosis, a regional migratory osteoporosis, and idiopathic chondrolysis of the hip. So the clinical features, the low backache, which radiates around the trunk or down the limbs. So this is the osteoporotic pain. Okay, low backache radiates around the trunk or down the limbs. Loss of height and appearance of the thoracic kyphosis and approximation of the rib margin to the iliac crest. Patient appears older than his or her years. So appearing as more older when compared to the exact age. And history of the fractures. So this is the osteoporosis. Physical examination, the measurement of the height, detection of the kyphosis, blue sclera, hepatosplenomegaly, like systemic diseases, or skin pigmentation, maybe the Cushing's, or thyroid or hyperthyroidism. Okay, so these are all the physical examination to rule out all the secondary causes, or a chronic alcoholism or chronic smoking therapy. Okay. X-rays are very important. The post-menopause osteoporosis, a trabecular resorption and cortical resorption, senile osteoporosis, endosteal resorption, hyperparathyroidism, subperiosteal resorption. I think you have to sit with radiology postgraduates. So ask them what about this cortical resorption, trabecular resorption, endosteal resorption in X-rays. Okay. So that's how we have to take care of, you have to learn many things from our colleagues. So as a physician now, should be very friendly with almost all the branches of the medicine, because a lot of the cases are interrelated. So some cases are interrelated between you and dermatologist, some are between you and the surgeon, and you and orthopedics, you and radiologist, you and biochemistry, you and pathology, you and microbiology. So the interactions are very, very important. So don't think that you are so great. So we are all dependent. We are all dependent on most of the other branches. See, this is the Neer-Popper score, grading of the vertebral fractures. Grade 0 is the normal. Grade 1, mild deformity, 20 to 25% reduction of any vertebral height. You compare the height of the vertebrae. And the first picture, second picture, third picture, and the fourth picture. First see the grade 0 is the normal height. In the grade 1, a mild deformity, maybe 20 to 25% reduction in any vertebral height. What about the grade 2, third picture, moderate deformity. So about 25 to 40% reduction in the vertebral height. And see the last one, grade 3, severe deformity, where more than 40% reduction of the any vertebral height. So this is very important. So whenever you suspect the osteoporosis, whenever you see the vertebrae, so you have to see the reduction in the vertebral height. So that is very, very important. The same thing you see in the X-rays also. X-rays also. So osteoporosis produces the increased radiolucence of the vertebral bone. 30 to 80% of the bone tissue must be lost before to recognize abnormality can be detected on the spinal X-rays. So by the time it is seen on X-rays, so there is a loss of 30 to 80% of the bone tissue. Lesions less than 2 centimeters may escape the detection. What is the general treatment and the preventive measures? Nutrition. Nutrition means calcium and vitamin D3. So the calcium dose increases with the age due to decreased absorption. So as age increases, now calcium absorption will be impaired. So you have to give a lot of calcium from the oral, per oral. Decreases the bone loss by 1% per year. Greatest benefit in the elderly, late menopausal, and those with the low baseline calcium intake. So that is about the calcium. What about the vitamin D? So recommended intake is 800 to 1000 international units. The calcium also you can remember as 1000 milligrams. So calcium 1000 milligrams, vitamin D 1000 international units. Calcium and vitamin D, augmentation of the other agents. Given to all an osteoporosis therapy. So we give calcium and vitamin D to all people with osteoporosis therapy. Patients receiving the corticosteroids therapy. Those with are at risk of the deficiencies. So we have to give the calcium and the vitamin D. Coffee. Recommended less than the 4 cups. May reduce the calcium absorption. Some association with increased bone loss and the fracture rates. Okay. So coffee, increased bone loss and the fracture rates. Vitamin K may help with the bone metabolism and reducing the urinary calcium excretion. No recommendations for the supplementation. No association between the comadin and the fractures. Comadin is now the vitamin A. So it is the RDA of the 700 micrograms. High levels have been associated with increased risk of the hip fractures. Magnesium. Some epidemiological studies showed correlation with increased BMD in elderly and the females. Easily obtained on the daily food intake. Deficiencies may exist in the elderly and those with the GI malabsorption. So calcium, vitamin D, vitamin A, magnesium, and alcohol, ethanol, can suppress the osteoblasts. So moderate intake in women with higher BMD and decreased risk of the hip fractures. Heavy intake increases the risk of the fall and the hip fractures. See the picture. What it has written? The doctor said he needed more activity. So I hide his TV remote 3 times a week. రిమోట్ పక్కన పెట్టేస్తున్నారు మూడు ఆ రిమోట్ కోసం ఎదుగుతున్నారు అనమాట రిమోట్ కోసం ఎదుగుతా ఉంటే ఫిజికల్ యాక్టివిటీ ఓకే ద డాక్టర్ సెడ్ హీ నీడెడ్ మోర్ యాక్టివిటీ చెప్తే వెళ్ళడం లేదు బయటికి డాక్టర్ గారు చెప్పారు యాక్టివిటీ అంటే నో యాక్టివిటీ అట్ ఆల్ టేకింగ్ రెస్ట్ సో హైడింగ్ ద టీవీ రిమోట్ 3 times a week and searching for the TV remote he is making some activity. Okay, so that is the picture there. So that shows the importance of the activity. So rehabilitation exercises, strengthening muscles, backs and the legs is very, very important. Strengthening exercises. A prospective 10-year study showed the decreased risk of the vertebral fractures. Orthotics, weight training, pain management, and avoiding the substance of the abuse like alcoholism and the smoking, or nowadays no drugs. So these are very important. See, these are the postures. Right posture and the wrong posture. See while reading. Again, right and the wrong for lacing your shoes. Okay, right posture and the wrong posture. So these postures. So bending forward should not be advised for osteoporotic individuals. No flexion exercises, only extension exercises, because already they are in kyphosis. So they're lifting any object. So that is how they have to lift it. Okay. So this is the better posture, sleeping postures. Okay. And right lateral or the left lateral are in the prone position. So these are the strengthening exercises. Okay. These help to improve the individual's overall physical function and the postural control. See the upper back and shoulder extension exercises performed with the supine supported. See the back extension exercises in the sitting position. This position avoids or minimizes the pain in patients with severe osteoporosis. See, these are the extension exercises. In the prone position, with a pillow under the abdomen to avoid the hyperextension. So to increase the effect of the back extension strengthening, weight is added there. So strengthen the lumbar extensors and the gluteus maximus muscles. So these are the arm loading exercises. So arm press. So stand facing a wall about 50 centimeters away from it, with your feet slightly apart, arms bent at the elbows and hands at the shoulder height. Okay. So push your body back to the striking position. See the wrist exercises. So these are very, very important and very easy to advise them, and it is very easy to carry at their home. So these are all the important. Some exercises, some walking, simple walking. Okay, some jogging or simple exercises, the foot exercises, high impact activities. So these are very important. So the balancing. Okay. See the flexibility exercises. See the yoga. So these are very, very important for all the osteoporotic individuals. See all these exercises. Okay. So again, I'm showing the pictures. See the flexibility exercises, balancing exercises. Okay. Weight bearing exercises, wrist exercise, arm press, lumbar extensors and the gluteus maximus, extension exercises, back extension exercises. Okay. Upper back and shoulder extension, strengthening. So sleeping on the right lateral or left lateral and lifting the objects. Okay. So these are all the important exercises one should advise to the osteoporotic individual. So it is very easy to advise and gives them very, very good benefits as far as the osteoporosis management is concerned. So what's spending some time on exercises for these population. Now move on to the most important part of the talk is the drug therapy. Okay. Inhibitors of the bone resorption. The calcium. So your hormone therapy, estrogens or the progesterones, serums, bisphosphonates like alendronate, zoledronate, risedronate, ibandronate, calcitonin. Okay. Or parathyroid hormones. So these are the stimulators of the bone resorption, parathyroid hormone injections, etc. So these are the two types. One is inhibition of the bone resorption. Inhibition of the bone resorption. What are all the drugs? So these are all the drugs. So your calcium, your estrogen therapy, your serums, bisphosphonates, calcitonin. So they inhibit the bone resorption. So they act at the level of osteoclasts. Okay. So what about the bone formation? So stimulation and the osteoblasts. So parathyroid hormones. These two are very important. So inhibitors of bone resorption and stimulation of bone formation for parathyroid hormones. So dual action. So some drugs have both the things. Okay. They are the strontium ronalate, vitamin D and its active derivatives, ipriflavone and anabolic steroids. So these four are having the dual action of both stimulating the bone formation and inhibiting the bone resorption. So what about the calcium and the vitamin D? So I told you the 1000 milligrams increased over 65 years after the menopause, pregnancy, stilting, etc. And vitamin D, again the 1000 international units, remember like that, 1000 international units. And over the 70 years, again 800 to 1000. This is the hormone replacement therapy, estrogen. They reduces the rate of the bone loss, reduces the fracture risk in the post-menopausal women. Adverse effects, WHA. What do you mean by WHA? Calcitonin, it reduces the bone loss in the post-menopausal woman, the bone quality. Effect on the spinal fractures. So 200 international units daily, nasal spray. It is available in the nasal spray and high tolerability. Okay, so that is the calcitonin. So nasal spray about a 200 international units once a day. So to avoid spinal fractures. Bisphosphonates, they are the gold standard drugs. So post-menopausal osteoporosis, or senile osteoporosis, male osteoporosis, etc. Here the alendronate, zoledronate. Okay, so these drugs are available here. And contraindication is the esophageal irritation. So alendronate we give 70 milligrams per week and zoledronate once in a year. So 5 milligrams IV in about 100 ml of the normal saline, yearly infusion. See the strategies for reducing the falls and the fractures. So they maintain the physical activity to avoid the kyphosis. So they have put on brass there. They provide a safe home environment, balanced training, ambulatory support when appropriate, avoid the sedative medications. This is a very, very important osteoporotic individuals. So don't advise the sedatives for a severe osteoporosis individuals. Otherwise, no, they may fall in the washrooms and then get the fracture of the hip or fracture of the vertebral fractures or Colles fractures are very important. So sedation one should be avoided in all the elderly population, especially elderly population, those who are more prone for the fractures. Minimize the other contributing medical problems. Hip pads in the frail elderly. So these are the hip pads. Even though they fall on the ground, it protects from the fracture head of the neck, etc. Neck of the femur. Prevention of the hip fractures in the patients with the high fracture risk. See the low initial bone mass, vitamin D receptors, estradiol, here the fracture risk factors. So these are all the very important things. See how they fall on the steps. So your actor Shravan Babu. So same thing. He got the head injury because of the fall from the steps. So treatment of the osteoporosis. So well-balanced diet is very important. Milk is very important. The second one is the milk and calcium tablets before the meals on empty stomach. Okay, fluoride capsules after the meals. So calcium tablets before the meals on the empty stomach, they absorb better. So vitamin D from the sun rays and exercise, walking, mild athletic activity, plus prescribed back exercises. Soft shoes with a cushioned insoles. So shoes are very important, insoles. So that is the very, very important, very important. Big thanks to Nectar, a great fellow, who has painted a lot of the things now. Very, very greatest of great. So it is all the treatment of the osteoporosis. Okay. So the diet is important, calcium is important, fluoride is important, sunlight, that vitamin D is important, activity is very important. So physical activity is also very important. So identify the risk factors for osteoporosis. So avoid smoking. Identify the contributing factors, medical history, sedentary osteoporosis, physical examination, DEXA scan, X-rays, laboratory evaluations. So the four major goals in the management of the osteoporosis: to prevent the fracture, that must be the first goal. Then stabilize the bone mass or achieve the increased bone mass, improve the bone mass. and then they relieve the symptoms of the fractures and the skeletal deformity, then the maximize the physical function. That's the quality of the life. So these are very important. Improve the bone mass, avoid the fracture risk, and then give them a symptomatic relief if the patient is asymptomatic. And then most important one is the improve the quality of the life or physical activity. So these are all the phytoestrogens. Phytoestrogens may be useful for preventing the bone loss caused by the estrogen deficiency in the woman. What are the dietary sources? Isoflavones. So these are also available in the drugs also there. Some pharmacological drugs are also there with isoflavones. Genticin, diadazine, glycitin, equal, lignans, enterolactone and enteroladiol, oil seeds, flax seeds, cereal bran, legumes, and less alcoholism, commeristol found in the alfalfa and the clove. So these are all the dietary sources of your phytoestrogens. Pain management. Pain has been reported up to 62% of the female patients with osteoporosis. Various pain origins for the osteoporosis, including concurrent degenerative disc disease or osteoarthritis and the vertebral fractures. See, elderly individuals know. So already they must be having some element of the osteoarthritis that causes the pain. And maybe the degenerative disc disease, maybe the L3, L4 or C3, C4, C5, C6. So cervical disc problem or lumbar disc problems, etc. So to improve the posture, superficial heat like infrared therapy. If pain persists, penetrating the heat like ultrasound or shortwave diathermy. So there are all the physiotherapy measures. If pain still persists, rule out the malignancy, especially multiple myeloma or secondaries, and back strengthening extension exercises. And some analgesics, acetaminophen or simply or paracetamol or ibuprofen, naproxen, indomethacin, etc. and etc. on SOS basis, not on the long-term basis. If you want to use them on long-term basis, then we have the paracetamol. So maybe the 1000 milligrams paracetamol is also available. Maybe you can give it one tablet of 1000 milligrams paracetamol at bedtime or after the lunch. Opioid combinations, so better to avoid them. If you use the opioid combinations, common associated side effect is the constipation. So again, the elderly individuals began the constipation is again a big problem. So the morphine, oxydokin, so they will be available in the anesthetists who are practicing the pain management, pain clinics, palliative pain care. So the same is diagrammatic representation of your osteoclast and the osteoblast. So here the osteoclast, inhibition of the resorption, here the stimulation of the formation. So already I told you the estrogen therapy, etc. That is hormone replacement therapy. SERMs, that is a selective estrogen receptor modulators. So your hormone replacement therapy increases the BMD, decreases the hip, vertebral and other osteoporotic fracture lips, increase the risk of the CV events, thromboembolism, breast cancer. So that is the reason hormone replacement therapy is not ideal for all the women. Okay. So the chances of having the breast cancer, the chances of having the embolic strokes, the chances of having the CV events are more in those people are on the HRT, that is hormone replacement therapy. So hormone replacement therapy is a double-edged weapon. So you have to see the gain versus the risk. When the gain is more, you advise them. When the risk is more, avoid them. Okay. So this is the one word about the hormone replacement therapy. It is not good for all the individuals. So some individuals, they are the higher chances of having these events. So estrogen is effective in inhibiting the bone resorption and increasing the BMD by binding to the estrogen receptors on the bone and blocking the production of the specific cytokines that increase the number of the osteoclasts and prolong their lifespan. So that is how the estrogen helps you. Estrogens can be administered orally or intravaginal or transdermal or parenteral and by the topical application to the skin also. So estrogen patches are also available. Estrogen is usually taken in a continuous daily dosage regimen or in a cyclic regimen. Cyclically administered estrogen is usually taken once daily for 3 weeks, followed by 1 week off the drug, or once daily for 23 days, followed by the 5 days without the drug. So all the people, then you know that how they use the oral pills, no? So the gap, etc. So that's how the hormone replacement therapy you give it. Regarding the safety of the long-term use of the hormonal therapy, this treatment should be reserved for the women unable to tolerate the non-estrogen therapy. Research evidence has shown that lower doses of the CE alone or CE plus MFA 0.3 milligrams bar 1.5 milligrams daily significantly increase the spine and the hip BMD from the baseline within 2 years of the therapies. So these are the different drugs: estradiol, estrone sodium as the etoposide, estropeptide, estradiol, conjugated. So these are the different, and cautions are there. Undiagnosed abnormal genital bleeding, known or suspected breast cancer. So already I told you the venous thromboembolism or thromboembolism, pulmonary embolism. So better to avoid these estrogen therapies in such individuals. So the different drugs are there: estrogen, estrone, estradiol, estriol, E1, E2, E3, etc. Now move on to the important drugs, the SERMs. The SERMs are nothing but selective estrogen receptor modulators. So here the raloxifene. Raloxifene hydrochloride is a non-steroidal benzothiopiene derived with mixed estrogen agonist or antagonist activity in specific tissues. Prevention of osteoporosis in post-menopausal women who use this raloxifene. Biological actions are principally mediated via binding to the estrogen receptors. This binding results in the activation of the specific estrogenic pathways and the blockade of the others. Raloxifene acts like estrogen to prevent the bone loss. Dose 60 milligrams OD. Some adverse effects again like a venous thromboembolic disease, mostly in the sedentary individuals, because sedentary individuals are more prone for the thromboembolic strokes. So in such individuals on pronged sedentary lifestyle, so better to avoid them. Otherwise, this is a good molecule, raloxifene, 60 milligrams OD. There will be the modest increase in BMD of the spine and the hip, decreases the bone turnover. Multiple outcome of the raloxifene evaluation. The study, 3-year study, nearly 7,700 women with osteoporosis were studied here. The study name is the MORE, that is multiple outcomes of the raloxifene evaluation. Postmenopausal osteoporosis plus or minus previous vertebral fractures. Some side effects like hot flushes, leg cramps, increased thromboembolism. Now the calcitonin therapy. Calcitonin is an endogenous hormone secreted by the thyroids, parafollicular glands in the mammals. Inhibits the osteoclast formation, development and activity, and promotes the osteoclast apoptosis. It acts quickly in the treatment of osteoporosis. Calcitonin. Derived from a salmon's ultimobranchial gland, is utilized due to its greater potency and prolonged duration of action when compared to the mammalian calcitonin. Indications: patients, hypercalcemia, osteoporosis in women more than 5 years after the menopause. Used for pain associated with osteoporotic fractures also. Patients with vertebral crust fracture reported a significant decrease in the pain. Doses 200 international units daily, nasal spray formulation. So this is also in a nasal spray, that is the calcitonin. See, the postmenopausal, at least 5 years postmenopausal period, unable to tolerate the other agents, nasal spray or subcutaneous injection or the oral, minimally inhibits the bone resorption, possible analgesic effect for acute vertebral fractures. So here is the proof trial. At 5 years, 33% reduced risk of the new vertebral fractures. After 5 years, increased dose 400 milligrams required to perpetuate BMD increase. Side effects as the nasal spray, you have the nasal irritation, some nausea, local inflammation, and the flushing. Otherwise, it is safe in most of the individuals. Now the bisphosphonates. They are analogs of the pyrophosphate. Bisphosphonate therapy should be considered first-line therapy for the treatment of the osteoporosis, along with your lifestyle modifications or your exercise therapy, etc., and also with the doses of the calcium plus vitamin D. Your first generation, etidronate and toludronate, now we are not using them. Second generation, we have the alendronate, pamindronate, and ebandronate. They are available for the prevention and the treatment of the post-menopausal osteoporosis. And the third generation, they are very much available. That is the risedronate and the zoledronate. They accelerate the apoptosis of the osteoclast, reducing their number, disruption of the cytoskeleton, and ruffled border of the osteoclast, affects the osteoclast precursors, and inhibit their differentiation by suppressing the interleukin 6. And second and third generation bisphosphonates have important metabolic effects on the mevalonate pathway for isoprenoid lipid synthesis. Interference with the mevalonate pathway and may impart the anti-tumor action on bony metastasis also. So the bisphosphonates helps in many ways. So here the statins also helpful in the osteoporosis. So the risedronate, ebandronate, and the zoledronate. So let us talk on the zoledronate. Indicated in the hypercalcemia, bony metastasis, and Paget's disease. Proliferation of the bony metastasis of the prostate, the breast cancer, and multiple myeloma cells may be arrested here. Alendronate, male and postmenopausal osteoporosis, and also the treatment of steroid-induced osteoporosis. So it is helpful for steroid-induced, postmenopausal, and senile osteoporosis. Daily or weekly dosing inhibits the osteoclast, increases the mineral density. Spinal fractures, reduces it. Hip fractures, reduces it. Side effects, gastric irritation and ulcers. And one should not use the creatinine clearance less than the 35. So this is the osteonecrosis of the jaw because of this bisphosphonates therapy. Risedronate, this is useful for the glucocorticoid induced osteoporosis and also like the male senile osteoporosis or postmenopausal osteoporosis. Again, daily or weekly or the monthly. Ebandronate, the same thing here for the postmenopausal osteoporosis. Decrease the risk of the vertebral, not the hip fractures, by 50% over the 3 years. So ebandronate reduces the risk of vertebral fractures, not the hip fractures. Zoledronate is a very important drug for the postmenopausal osteoporosis. So just once in a year, 5 milligrams. Reduces the incidence of spine fractures and also the hip fractures and also the Colles fracture, non-vertebral fractures. So all the 3 types of the fractures commonly involved in the osteoporosis can be reduced with this zoledronate therapy. Acute phase reactants like arthralgia, myalgia, fever. So they're common, but most of the people, they tolerate the zoledronate. You have to give it in a 100 ml normal saline over about 20 to 30 minutes. So sometimes these bisphosphonates may cause atrial fibrillation. Sometimes combination therapy is also advisable. So bisphosphonates, your hormonal therapy, and also your serums are all classified as anti-resorptive drugs. They operate through the different mechanisms of the action. They all act on the osteoclast. So to reduce the bone loss, so to improve your bone density. So they can be used synergistically, like all your OHS. So you can add the metformin, you can add the sulfonylurea, you can give the dapagliflozin because they act differently. So even though they are all oral hypoglycemic agents, in the same way, the bisphosphonates, hormonal therapy or serums, so they are act on the osteoclast activity in different ways. So you can combine them. Parathyroid hormone, very important. So this is the teriparatide, is administered as a once daily injection, is approved for use up to the 24 months. Up to 2 years you can use them. So once a day, subcutaneously. Administered as a daily subcutaneous injection, maybe 20 mcg. Indications used for the treatment of patients with osteoporosis, both men and the women at high risk of the fractures. See the BMD here, less than 3.5. T-score less than 3.5. So very severe osteoporotic. And those with the pre-existing fragility fracture, already history of the fractures. So the daily subcutaneous injections are used in corticosteroid-induced osteoporosis also. So it's senile in post-menopausal women, also in the steroid-induced osteoporosis. So you can use this teriparatide, that is the parathyroid hormone, 20 mcg OD subcutaneously for 2 years. So the efficacy, so they are very good drugs. They reduces the new vertebral fractures. So here the T-score of up to minus 3.5, fractures T-score minus 2.5, and those who fail 2 years of the bisphosphonate therapy also. So you can give the parathyroid hormones. Side effects, some dizziness, leg cramps, osteosarcoma seen in the rat trials, contraindications for patients, prior radiation therapy of the skeleton, bone metastasis, hypercalcemia, or history of the skeletal malignancy. So these are the contraindications to use the parathyroid therapy. Fracture prevention trial. So reduces the vertebral and non-vertebral fractures respectively. So all the fractures can be reduced with the parathyroid hormone therapy. So what are the synergies? Your teriparatide and alendronate. So combination of your PTH and these things. Say there's a spine and the femoral neck BMD increased greatest in the PTH only group. Alendronate impaired the PTH anabolic activity. So recommended that bisphosphonate therapy follows the PTH. Simultaneous use are not generally recommended. So generally they are not recommended. Both the teriparatide and alendronate. Okay, that is the bisphosphonates. So this is the monoclonal antibody. So demosuban, human monoclonal antibody that has high affinity for the rankle and blocks the binding of the rankle to the rank. Give subcutaneously 60 milligrams every 6 months. Increases the BMD at all the skeletal sites and decreases the bone turnover markers at the 24 months. Adverse effects, dysregulation of the immune system, potentially leading to the infections or the malignancy. So this is the denosumab. Statins, so they are also good drugs. The drugs that were developed and are widely used to lower the serum cholesterol by inhibiting your HMG coenzyme reductase, the rate limiting enzyme for the cholesterol synthesis. Statins, particularly newer ones, are of potential value for the treatment of the osteoporosis. So statins you can continue in the osteoporotic individuals. So evaluating the treatment efficacy, so repeat the BMD testing every 1 to 2 years while the patient's on therapy. So this year minus 3.5, next year maybe the minus 3 or minus 2.5 or minus 1. So that means you are gaining more and more. Suppose the same BMD, the same values, so we are degrading the fellow. So step-up therapy, you can use them, but ensure the compliance also will be good. Evaluate for secondary causes if the patient is having any improvement. So when you stop the therapy, that is very important. So far you have learned some drugs, you have known the some drugs like your hormone replacement therapy or SEMS therapy or the bisphosphonates or parathyroid hormone or the statins or monoclonal antibodies, etc. So there is no real guidelines. So when to stop these therapies. Study to compare the stopping the alendronate after 5 years versus continuing for the 10 years. Discontinuing the alendronate after 5 years showed the moderate decline. No significant change in the non-vertebral fractures. Slight increase in the clinical vertebral fractures. So stopping for up to 5 years does not significantly increase the fracture risk. So the patients with very high fracture risk may benefit from the continued therapy. So it is up to you. So as a clinician, if the patient is at high risk of getting the fractures, refractures or past history of the fractures, etc., with a lot of the side effects, a lot of the risk factors, so better to continue the therapy. So don't stop these therapies. So complications, the fractures. hip fractures. Consequences. After the first hip fracture, 30% of the patients will fracture the second hip. Okay. Nearly 20% of the women who develop a new vertebral fracture will fracture again within a year. 5-year survival rate following vertebral fracture is equally worse as the hip fracture. Bone loss cannot be completely reversed, but fracture risk can be decreased by the intervention. 1-year mortality following hip fracture in men is twice that of a female. So management of the complications, hip fractures, etc. So they have the kyphoplasty, vertebroplasty. So risks there. So these are some surgical interventions also will help us in controlling these pictures. So thank you very much for your patient hearing.